Okay, welcome to part 3 of our look at small bowel obstruction. And in part 3, what I'm going to do is look at some interesting cases and see what we can learn and how we can really optimize our ability to help manage patients. So in this case, patient has abdominal distension, and what you see is a markedly dilated stomach, really fluid-filled. You also see what looks like extraluminal air. That's a bad sign because it means there's assuming the patient had no procedure, like a biopsy or surgery, this means something is perforated. And as we scan down, we can see very nicely distended stomach and distended small bowel. But you see not only the distended stomach, but pneumatosis in the bowel. This is a classic appearance of air in the bowel wall, which basically means infarcted bowel. You can see the mesenteric vessels are really tiny. This patient has a lack of flow to the bowel is not enhancing, but a very impressive example of pneumatosis of the patient's bowel. And you can see it literally begins in the duodenum and extends throughout the small bowel down to the terminal ileum. This is infarcted bowel. This patient basically has no chance of survival. Now, what was the cause of this extensive pneumatosis? You can see also portal venous air, which occurs when you have infarction. And this was due to a low flow state. You can see the mesenteric vessels are barely visible. And this was a very impressive example of infarcted bowel. So think about the things we look at. We look for free air. That's a late sign. We look for portal venous air. That is a late sign as well, because when you see portal venous air, it usually means the patient has ischemia and infarction. You can see in this case, the air went from a little bit to very extensive very quickly. And you can see the real impressive changes in the bowel wall. Now, again, water was the contrast agent used here. You can get air fluid levels in bowel, obviously, but pneumatosis looks significantly different than that. You can see it here on the cinematic rendering as well. So I show you these images and back up and re-show you the images to make the point that you need to really understand what pneumatosis looks like so that you can pick it up particularly early. Not everybody with pneumatosis is going to die. You know, it used to be said that if you had portal venous air, it was 100% mortality. Now it's probably more like 60 to 70%, particularly if you can pick things up early. But in a case like this, when the bowel has pneumatosis, literally entire small bowel, and you can see by the appearance on the cinematic, the lack of blood flow to the bowel, this is infarction, and basically it involves essentially the entire small bowel and is beginning to involve the colon, and this patient unfortunately expired. But again, understand what pneumatosis looks like. Another patient, right lower quadrant pain, we see dilated small bowel and we follow it down. The bowel begins to be more dilated, but is that small bowel or is that larger loop being colon? You can see this haziness in the right lower quadrant. Again, we're looking, and then we see this large tubular structure. This is not small bowel. This is the ileocecal valve. This is large bowel. And what you're talking about here is small bowel obstruction due to a large bowel process. And this appearance, this coffee bean appearance of the cecum, is a classic appearance for a cecal volvulus. And you can see the transition point of the small bowel is near the ileocecal valve. You can see there's some free fluid present. This is a patient who has a cecal volvulus. Here it is nicely shown when you look at it and you scroll down the dilated loops of bowel. You're following it down to the right lower quadrant, and then you see the cecal volvulus and you see the transition of the small bowel distally. And so when we talk about small bowel obstruction, it can be due to a process in the large bowel. It can be due, in this case, of course, to a cecal volvulus. It also can be due to a tumor of the cecum, like a colon cancer. We've also seen small bowel obstruction due to appendicitis with appendiceal abscess. So when you see small bowel obstruction and you track it downward distally, it may be beyond the small bowel, the primary process, and in this case, it was the cecum with the cecal volvulus, but other cases can be other pathology of the large bowel, very nicely shown. And a really good example of a cecal volvulus, and here's a schematic drawing of that. And remember, on our image, here's what we saw, right? We saw where the ileocecal valve was. This is the appendix, by the way, and a kind of a really nice twist, and you have this large sac, a very classic appearance of a cecal volvulus. Now, we mentioned about transitions. Here's a good example of dilated bowel, and the bowel is extending down into a hernia. This is an incarcerated inguinal hernia. We see many inguinal hernias. Most are just not of any clinical importance, but they can become important over time. But this one is important at presentation because when we follow the dilated loops of bowel downward, we see a transition. We see this narrowing of the bowel, the enhancement of the bowel. That is an incarcerated hernia, shown nicely right there. And here it is very nicely shown in the coronal view, the dilated loops of bowel. We are following them downward, and here we see the transition, small bowel into hernia with obstruction. This is a classic incarcerated hernia. This is a surgical emergency. Now, I don't see any fluid around the distal bowel, so this hernia was reduced and the patient did not need bowel resection. Again, the importance of early diagnosis prevents resection of bowel. The hernia was reduced and it was fixed, and the patient did not need bowel resection. But if it was later, the patient would need resection. So again, a very nice example showing you the transition point of large bowel, the transition point of small bowel. I showed you the large bowel transition in the prior case of volvulus. And here it's a distal obstruction, not due to a primary small bowel process like tumor, but due to a hernia, very nicely shown. And again, here it is on the sagittal view. So the coronals and sagittals can be very helpful if you're uncertain where the hernia is and its extent. In this article by Paulson, external hernias are the second most frequent cause of small bowel obstruction. In the early 1900s, which was a lifetime ago, it was the number one cause of small bowel obstruction, these hernias. But fortunately, hernias are less frequent these days, less manual labor, and patients who do have hernias that are significant will get surgery to repair them at an earlier stage. The hallmark of small bowel obstruction due to hernia is the presence of dilated bowel up to the hernia sac, followed by decompressed bowel exiting from the sac, just like we saw in the last case. Another example, really dilated small bowel, okay? And so we can go through many possibilities, but it's following the dilated loops of bowel downward. I would begin to worry here, could I have pneumatosis? This might be just like a string of beads layering of air, but you want to look carefully at that. We track it downward. Here's the hernia beginning in the left lower quadrant. Here it is again into the hernia sac, and we track it further down. This is, and you'll see it better on the coronal views and on the sagittal views, an incarcerated hernia. You can see fluid around the hernia sac in the left lower region. And once I see fluid, to me it means the bowel is ischemic and this patient needs emergency surgery. Just a very nice example of an incarcerated hernia. And here it is with volume rendering, showing you the dilated loops of bowel tracking into hernia, the free fluid around the hernia, and the need for surgical intervention. So just a really nice example. Now, we can see large bowel going into hernia as well as small bowel. Here's an example of markedly dilated bowel loops, which we track downward. And the patient has both a large and small bowel going into this large hernia. There's fluid present. This is an impressive hernia. There's cecum, there's small bowel, there's some fluid and inflammation. This is, again, a patient about to develop ischemic bowel. If the patient goes to surgery earlier, this can be reduced. It's a complicated surgery, obviously, with lots of bowel in the hernia sac, but it's a lot less complicated before the bowel is ischemic. And just a really nice example. And this also shows you the spectrum. Now, you don't need to have a massive hernia like this to develop symptoms to suggest ischemia. The other two cases had far less bowel going into hernia. You can have a small knuckle of bowel, but if it's twisted or the hernia is stuck because it's a small little opening, even the smallest amounts of bowel can result in ischemia. Here it is very nicely shown, that same case with cinematic rendering. Just a really nice example. Now here's another example. We showed you inguinal hernias. Now here's a hernia in the abdominal wall. We see lots of hernias at the level of the umbilicus. We see more hernias now because of patients having laparoscopic surgery and hernias occurring near trocar sites. But here you can see bowel going through a hernia near the umbilical level, and you can see it very nicely here. You can see not only the stranding, which is the hernia, which is just fat, but this loop of bowel here and this narrowing of the loop of bowel right by the umbilicus. This patient had severe pain, was developing bowel obstruction, was symptomatic, and the patient had surgery. Now you ask the question, can you just simply reduce this bedside? Sometimes you can, but I think the surgeons are concerned that that might result in perforation, and if they can't reduce it, they may have caused more problems than they solved. And this is an easy enough laparoscopic surgery to do, and that's what will typically be done. Another patient, acute abdomen, left lower quadrant pain. Again, dilated loops of bowel, we're tracking them downward. We're looking for the transition point, which you begin to see right here in the left lower quadrant. You can see it again. It looks like a knuckle of bowel coming through, inflammation around it, the dilated bowel leading right up to it. And here it is again as you go on the sagittal view, really nicely shown, that knuckle of bowel coming through this defect. That's an incarcerated hernia. You can see it here very nicely on the volume rendered views as well, with that knuckle of bowel. And remember, we said you don't need to have a large amount of bowel through a hernia defect to cause problems. It could be a small amount. And this is a nice example on the cinematic as well of a classic hernia. Where is it? It's through the bowel wall, and this was a spigelian hernia in the left lower quadrant. And just by definition, a spigelian hernia is a rare ventral hernia, which is defined as herniation of abdominal content or peritoneum through a defect, namely the spigelian fascia, which is comprised of the transversus abdominis and the internal oblique aponeurosis. Patients describe a painful or painless bulge in their abdominal wall, particularly when standing, that may acute or be of chronic onset. Depending on the contents within the hernia, pain may vary greatly in terms of severity, character, and location. Commonly, patients will present in the urgent setting secondary to complications associated to the hernia. So a really nice example, the spigelian hernia often becomes a surgical emergency. Here's another example of a femoral hernia. You can see the hernia tracking downward, and you can see here proximal to the hernia, the dilated loops of bowel. So one of the things you can see is that you have a spectrum of hernias, but the CT appearance of the bowel is the same. The bowel is dilated, fluid filled. You're looking for transition points. Follow the axials, follow the coronal. Is it a defect in the abdominal wall? Is it periumbilical? Is it a trocar site? Is it an inguinal hernia? Is it a femoral hernia? Is it a spigelian hernia? Look at the transition and look at precisely what we're looking for. Another example, abdominal pain and a palpable mass. Well, what you can see is the mass is bowel. It's small bowel with edematous changes. You have to worry that this is a ischemic small bowel, which indeed it was, and it's a midline hernia. Again, patients who've had surgery, you have thinning of the rectus muscle, you have all sorts of potential areas where you can get hernias. Just a really nice example. And to me, the emergent situation is really told to me by the fluid and inflammation within the hernia sac. As I mentioned, if you see a hernia and it looks clean, it may not be that much of a surgical emergency, but once you see haziness or fluid, to me that means you're about to develop or have developed ischemic bowel. So just a really nice example of that hernia. Sagittal view again shows the dilated, inflamed bowel and where the defect was. And you can see it was a small defect where this loop went through, which is causing a lot of the problems. And here's just a few more views. So again, a very nice example of a hernia causing bowel obstruction. Another example, here's a patient with perforation in the hernia. Remember one of the complications? I see fluid in the hernia. I might see some thickening of bowel. I worry about incarceration. If you don't treat it in a short period of time, you can have ischemic or infarcted bowel and perforation. So here I see pneumoperitoneum. I see dilated loops of bowel, which I follow downward. And then I see this air collection toward the left lower quadrant, which I then track through the hernia. Now you can see this air is extraluminal. You have hernias on the right and left side, but it's the left-sided hernia that has perforated. The bowel has perforated, the bowel has infarcted, and now you have a pneumoperitoneum. You have air in the hernia sac, but you don't really see the bowel very well. The bowel is infarcted. And this, of course, is a true surgical emergency, and these are the patients at risk to die, right? So it's not just morbidity, but it's mortality that also, and again, the importance of early diagnosis. This patient has these vague symptoms. It was a patient was in a nursing home, so probably wasn't watched that carefully. By the time they came to the hospital, this had already perforated. The patient had peritonitis. And these are the patients, again, that are going to be super challenging. But just a really nice example of ischemic bowel with perforation, with free air, and pneumoperitoneum, all very nicely shown. Now, what else? We talk about small bowel obstruction. We talk about adhesions. I showed you some nice examples, including the patient's feces sign in some cases with adhesions. We talked about hernias. I showed you a lot of different hernias, and I showed you some of the complications of hernias when they're not treated very early. Now, the third thing that causes bowel obstruction is going to be neoplasm, and that's in about 5% of cases. So let's do this. Let's take a short break, and we'll come back, and we'll look at the spectrum of tumors causing bowel obstruction. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.